The National Institute for Health and Care Excellence was set up in 1999 to standardise treatment in the NHS. NICE was asked to start to produce guidance on ways of improving people's health rather than treating ill health. In April 2013, NICE took on another responsibility for producing social care guidance and quality standards.
The purpose of NICE is to help reduce uncertainty within the health community in terms of providing inputs to patients. It is not intended to be a substitute for clinical experience and knowledge.
There are three types of guidance relevant to the Trust. These are clinical guidelines, technology appraisals, and public health guidance. Clinical guidelines are recommendations on the treatment of people with specific conditions and illnesses. Technology appraisals is guidance on prescribing advice and medication. Public health guidance are recommendations on improving people's health rather than treating their ill health. Everyone knows that NICE produce guidance, but they also produce quality standards, evidence summaries, and prescription advice. All these things are available on the NICE website. In the last couple of years, NICE have started to develop quality standards. Quality standards is a different kind of guidance. It's not mandatory. And obviously it's around quality, and they build on the mandatory guidance, they build on clinical guidelines, and they are an attempt to drive up the quality of services being provided.
The benefits to staff for using NICE guidance is it gives them confidence that the care they're providing is in line with the best evidence. The benefits to patients of implementing NICE is that they're receiving standardised, evidence-based care and treatment. The benefits to the Trust, apart from knowing that they're providing the best available care, it also means that they can meet CQC essential standards.
The Care Quality Commission is the regulator for health and social care, and all organisations involved in providing health and social care are required to register their services with them. The Trust has to demonstrate that its services are meeting the CQC standards by implementing NICE guidance. This shows that the Trust is delivering safe and effective, evidence-based care.
The role of the local NICE group and the team is to take the national guidance that NICE produces and to interpret it into our services. We send out a compliance status questionnaire for those guidelines that are relevant, that are filled out by services, and they help us to determine whether services are indeed compliant or not.
I attend the local services NICE group, and at the NICE group there are clinical directors, representatives from the physical healthcare team, from the audit department, from the involvement team, and of course by the clinical governance leads from the directorates.
The local services NICE group contacts myself as a member of the local services drug and therapeutics committee, and we're a multidisciplinary group with representatives from each of the clinical divisions, clinical directorates. And we assess each piece of NICE clinical guideline or NICE tag guidance to look at the implications for prescribing practice, to see whether we've got any gaps in current therapies, and really to work with the clinical directorates to identify what actions we need to put in place to meet the new necessary guidelines.
For some guidelines we are compliant, for others there is more work to be done, and that may involve training, may involve services becoming more aware of the guidelines, it may involve changes in practice. And what the role of the team is to help services with those tasks. The NICE group may determine actually that more substantial work needs to be done. And so what we will then do is encourage the development of a task group to take forward work around that particular guideline, and that will involve clinicians delivering the service, it will involve service users and families.
My role is to represent the service user's point of view in discussions about NICE guidelines, especially their implementation. So often I can think of things that employed professionals wouldn't necessarily think about, you know, so I can point out one or two things from a service user's point of view and just make sure that that kind of angle is taken into account in everything that NICE does.
People with serious mental illness on average die 25 years younger than the general population. My role is to make sure that NICE physical healthcare guidance is embedded into our services as well as mental health guidance. Doing this guarantees that the best practice is used and promotes health and well-being in both patients and staff.
Following this kind of work, then we are able to say, as a division, where we are in terms of compliance with NICE guidelines.
So a major role for our team is monitoring action plans and undertaking audits. This ensures that the services the Trust provides are continually improving.
And by complying with NICE guidelines, then we can assure ourselves that we are offering effective, supportive, high-quality services to service users and carers.
So you can find out about NICE on their national website. But for more locally relevant news, you can access our internet page, which you can find resources like our NICE newsletter on there, which has got more locally relevant information.
Hello, I'm Simon Smith. I'm the Executive Director of Local Services here in Nottinghamshire Healthcare NHS Trust. I've been working here as the Executive Director for Local Services for the last 7.5 years. And one of the things that we've been focused on for all of that time is how we can invest in excellence and in service development that follows through on our commitment to provide high quality evidence-based care. One of the things that we've done as part of that is to support the application of NICE guidance into clinical practice. And I, as the Executive Director, have, with Richard and Pauline's help, established a NICE guidelines group and have made money available specifically to that group to fund particular projects so that those projects can be developed in clinical areas to improve clinical care and patient experience. We make somewhere in the region of £200,000 a year available through that route, and it's used very specifically to implement NICE guidance or technology guidance to make sure that we're right at the edge of discovery around high quality care and good practice. One thing that I'm equally proud of is the way in which we disseminate the work that we're doing around NICE guidance and excellent practice. We had a conference which was nationally available for people to come to earlier this year, which I had the great pleasure of opening. We had colleagues who were writers of NICE guidance as well as people who work in the system to promote excellence talking, and people who were responsible for the promotion of particular projects locally. And that was an excellent way of disseminating the things that we're doing and engaging with a much wider audience so that everybody can understand the approach that we're taking.
My name is Michelle Malone. I work in Adult Mental Health Services. I'm Operational Manager there. The NICE project that I was involved in is around family interventions. So it relates to NICE guidance on schizophrenia and bipolar disorder. We started with one family champion per team, and we did some regular meetings with them and set some standards around at least one family in every team being offered the intervention at any one time. Prior to the workers being imposed, we did a NICE audit, and that demonstrated that we were only offering probably 1 or 2% of eligible service users this intervention. And so our aim over the sort of 3 years of this project has been to dramatically increase that, and we now think we're offering between 40 and 50% of eligible people the intervention, so we have managed to sort of dramatically increase that offer.
Well, my name's Neil. I work as a psychiatrist, a consultant psychiatrist within the Trust. We identified firstly that there was inadequate provision and that psychotherapy was expensive on a one-to-one level. And secondly, that importantly, there was no psychotherapy for relapse prevention. One type of therapy that we had available at the time was a group therapy called mindfulness-based cognitive therapy that could be delivered to groups of 10 or 15 people at a time, so it could potentially meet those problems with volume of demand. Because of the feeling that it was so successful, the local services have since that point funded a local services lead for mindfulness-based cognitive therapy, who's Tim Sweeney, and that post is now substantive and funded recurrently.
Okay, so my name is Tim Sweeney. I'm the mindfulness-based cognitive therapy clinical lead for Nottinghamshire Healthcare Trust. So we've trained around 30 people in the Trust now who are running MBCT groups to people that they work with, that they come into contact with through their daily work. And so typically what we find is that people's level of depression significantly reduces from the start of an MBCT programme by the time that they come to finish the programme 8 weeks later. We also know that MBCT can be helpful for many forms of difficulty, anxiety, stress, and a really helpful way of managing these sorts of day-to-day problems. So from this initial kind of project, what's happening is there's been a bigger than anticipated expansion of availability of MBCT because of the commitment to train more people. Basically because now we can see that this is a really helpful thing to do, and we want to roll it out more widely.
I'm Alinda Gillett, consultant clinical psychologist, and I work in the Intellectual and Developmental Disabilities Service. The project I've been involved in is in relation to the NICE guideline for children and adults with ADHD. What we produced in relation to that was a film about living with ADHD that used service users from our clinic who talked about what it was like for them to live with ADHD and how that affects them in terms of day-to-day life. We also produced the diagnostic interview film of how to conduct an interview to assess an adult for ADHD. That was really useful to us because we've been able to use it in our training programme. The money was also used to develop a range of leaflets and booklets. We developed a number of basic informational booklets on ADHD, which allowed us just to raise awareness about the condition, particularly in adults, which is often still quite stigmatised or misunderstood. We also developed a booklet about living with ADHD. This was for adults with ADHD themselves, but also useful to give to other people involved in their lives, such as their partners or families or professionals involved in their care. The resources we developed have recently won an Innovation Award. This is through an organisation called Medipex, who are an NHS academic and business innovation hub. One of the things that we hope to do with this prize is develop the resources in other formats, particularly using mobile or tablet devices, because we feel this is a really good and useful way to connect with adults with ADHD.
Right, I'm Stephen Coles. I'm a clinical psychologist in adult mental health. The project was on trauma and psychosis, which cut across several different NICE guidelines. Part of the impetus of the project came from the service user and survivor movement, which essentially was asking that we needed to move from asking what's wrong with you to what's happened to you. which is, I think is a fundamental shift in mental health services. And it related to a lot of research that's shown that trauma, including poverty, bullying, abuse, is linked to things like voices and psychosis. So that was the impetus of the project, and what we did was put on several training dates. Well, initially the money was used to set 3 training days up, but actually it really was enthusiastically taken on board by the Trust, who then matched the funding essentially, so they duplicated the training days. Then now some of the operational managers are looking at a community of interest around trauma and psychosis, so getting a network of people. And they're also, training development, are going to fund a national conference looking at 200-300 people to look at how do we develop trauma-informed services. So actually it's really been helpful in terms of stimulating the Trust in terms of looking at this area.
My name is Javid Khalik, and I do research and development for mental health services for older people. Alzheimer's Society information indicated there was something like 700 people from BME backgrounds, black and minority ethnic backgrounds, and very small numbers indeed were coming through to mental health services for older people. Part of the reason in terms of the information trawl and the investigation and research literature it indicated that there was a lot of stigma, shame, avoidance, lack of knowledge within the BME communities about the services available, or a reluctance to use them. And secondly, maybe those services weren't culturally appropriate for people from very different languages, faiths and racial backgrounds. We went out, we talked to an awful lot of BME community groups, created a project group, and then worked very hard in a small space of time to develop materials that were culturally appropriate. The other part of the work was to promote MESOP services, mental health services for older people, and the Trust services to the BME communities, and we were able to make a very, very good start on that. It was the first project of its kind in the country.
Hello, I'm Dr. David Connolly, Consultant Clinical Psychologist in Older People's Services in Nottinghamshire Healthcare NHS Trust. I've been involved in the Dementia and Comorbid Depression project from the outset. The project itself has mostly been about the dissemination of awareness and information, and the group has put together a very accessible information leaflet, a pamphlet that basically highlights the issues, some of the key signs and symptoms to look for, and the routes down which people might go if they, when and if they need to alert clinicians and other people to those problems. The money has been spent on supporting the work of the project group, but in very real material terms it's been spent developing the leaflet and the resources that are going to go out across the pathway that people's illness follows, as well as a series of training events and an ongoing culture of training healthcare staff in a greater awareness of the comorbidity of these two conditions. The fact that the money obviously is for a set period of time, we've had to plan for continuity, and it's the pathways and the information, the routes through which people interface with services that are going to outlive the project funding. Colleagues have worked very hard to put those structures in place, and those will live on once the money has been spent.
Hello, my name is Jackie Jevanoska, and I'm the Autism Spectrum Disorder Nurse Consultant and Clinical Lead for Nottingham City Asperger Service.
My name's Sarah Brennan, I'm one of the clinical pharmacists for local services.
So I was invited to attend the NICE project group, which basically is looking at insomnia within all different populations of people.
So we were able to develop links with Loughborough University Sleep Research Unit, and they were able to come and visit us and run sleep training courses.
Basically the purpose of that was to develop champions, and their role was really to take that training back and to develop different packages that would suit their area of speciality in terms of delivering that to people and helping not only the service users and their families but other professionals to understand how to manage insomnia. Medication has been shown to only be effective for use in very short-term conditions. What we need to do is to show people how they can take control, how they can use other resources with a much better understanding of sleep.
Following on from the sleep training sessions and the introduction of the leaflet and the booklet on sleep, we're going to do another audit which we hope will show what improvements have come about as a result of the work that we've been doing.
I'm Richard Fox, I'm a consultant psychotherapist and I was involved in the Obsessive Compulsive Disorder project.
My name's Virginia Cooper, I'm a cognitive behavioural therapist and I've been employed for 2 days a week on the NICE OCD project.
OCD guidelines are actually quite achievable, but sometimes because of the way in which services are organised, the pathways to help people get to the right treatments efficiently can be quite frustrating. One of the things that's come out of the project which has been really very pleasing has been that we've made very good links with a charitable organisation called OCD UK, which provides very good support for people with OCD.
About 300 people will have attended some kind of information or training event, and that includes people, clinicians of all different types, social workers, trained people, support workers, carers, people with OCD, people from other services, people from university providing mental health work and support.
The project will give clinicians more information and more confidence about how to assess, diagnose and treat OCD and about the different options that are available.
Hi, I'm Mel Homan. I'm an occupational therapist at Thornywood Adolescent Unit. Since we brought in the Dialectical Behavioural Therapy Project, DBT, we've managed to incorporate a parent group on a weekly basis where we bring in parents and train them on the skills of DBT so they can then use those with their young people. We also teach them about why we use DBT and how it helps their young person to recover while they're in hospital. Furthermore, we've added to this by bringing in a skills group where we teach our young people different skills on how to manage the issues they're struggling with, which can include different behaviours, including self-harm. We've also been able to start a consult group with Alison Tennant from Brampton Hospital, who's been expertly overseeing the project and helping us incorporate and embed DBT into our everyday practice. We meet regularly as a staff team to establish how we're going to move forward and what we need to do.
Now that we're facing more challenging financial times, it is equally important that we continue to fund projects that develop nice work in the Trust. And I am going to make sure that we continue to make money available in this way, non-recurringly each year, to promote the work of clinical groups as they develop nice appropriate services. There is a bidding process that takes place every year, and I would encourage you all to use that process to think about the way in which you want to improve and develop your services and understand the way in which they deliver high quality care for individuals that you're supporting.
I think when we worked clinically with people, it was a very positive feeling that actually those people within the cognitive stimulation therapy sessions that we worked with really found that beneficial. You could see a definite kind of sense of well-being of some of the people within that group and a real positivity that they took away from that.
We are looking at a culture change in terms of how we deal with carer issues, and it's very much around how we train staff to listen to carers and when it's appropriate to listen to them. There are a number of things happening around the Trust. We're starting to develop information for carers on the website. We're starting to develop training at the Recovery College.
Professionals see patients very, very infrequently, but we live with them 24/7, and we notice the differences between the behaviour from one week to another. And this is what I really desperately wanted to get through, that we are the experts by experience. Following the dementia with depression conferences, one occupational therapist came up to me and said, "I've only recently qualified, but you really made me think." So every penny spent on this project has been worthwhile as far as I'm concerned.
I'm a parent carer. My son has a learning disability, and that's the world where I come from. I personally saw this as a great opportunity to get across to the professionals a carer's point of view. What I always term as a bottom-up view is what we call triangle of care, where you've got the carer on board, the patients on board, and the professional on board, together at the table, making the right decisions first time round. It gives me a great big opportunity to step into this world in real terms and get listened to, and also it helps the people that I represent, other carers as well. So to me, it's been a real big advantage to me.
I have got involved with this for the simple reason as carers and the people we care for need to tell the people who make the decisions that there is other ways than the ones they may think is the way. Talk to each other, get involved, and it's our opportunity to put things the way they should be.
Implementing NICE guidance is a great way for people to look after their health and well-being.
NICE guidance encourages people to be fully involved in their care plan and take an active part in their treatment.
We need to make sure that all people with a mental health condition are aware of NICE and everything it does, so that they can make sure they get the best possible care at all times.
The NICE programme is something that service users and carers can and should be actively involved in.
I like to think that by being part of the NICE group and being a NICE champion, I can make a difference to the way NICE guidelines is implemented across the Trust, so that in turn that NICE guidelines can then make a difference to people's lives out there in the real world.